Welcome to today's webinar about shared decision-making in healthcare. Today, we are joined by Dr. Joy Chang. She is a gastroenterologist with the University of Michigan Health. Dr. Chang's clinical and research interests include improving the care, quality of life, and patient-provider communications for patients with eosinophilic esophagitis, or EOE. During her training as a GI and advanced esophageal fellow, she developed an interest in how patients' various preferences and values play into decisions about initiating and maintaining EOE treatment. Dr. Chang's research focuses on shared decision-making, health technology, specifically in EOE care, and patient-centered collaborative research methods. And with that, I will hand things off to Dr. Chang.
Hi, good afternoon, everyone. Thank you so much to APFED for inviting me to be part of this fantastic series. So I'd like to share with you some of my clinical passions about improving patient-centered care with shared decision-making and a little bit about how it plays into my practice for in EOE. And so just jumping in, so goals I'd like to cover today are defining what shared decision-making is and then review its benefits. Review key elements of shared decision-making, just so we know when we're in it and when we're not. Introduce ways to engage in shared decision-making, mainly as a patient, and share some helpful resources out there. So I want to open up by thinking about what makes a good decision. And this cartoon really captures that decision-making struggle when you're faced with really any choice in life. So while the brain is spending all this time making detailed lists about pros and cons and comparing, you got the gut and the heart just telling you something totally different. And if you're like me at all, this rational list making part of me is often at odds with my feelings, right? And if you're also like me, you might actually spend a lot of time stressing over what are the best decisions. So these are the decisions that really kind of shape and impact your life, not just should I spend another 10 minutes sleeping in, or should I impulse buy this pack of gum? And the kicker is the best decisions in life are not always concrete. They're not black and white, and there's not necessarily a clear right or wrong answer. The best decisions are informed decisions, and we'll talk a little bit more about what that is. And finally, the best decisions often involve expertise, so help from somebody who may know better or who has experience in making a similar choice. So in making the best decisions in healthcare, same rules apply. Because healthcare choices are rarely one size fits all and often complicated by other issues like other medical issues, finances, access to care, even the people around us, healthcare decisions are often not concrete and not easy at all. The best healthcare decisions are informed ones, and the existing data from studies we have do show that people want to take part of their decision-making around their health. And then finally, the best decisions in healthcare often involve expertise from at least two sources. So to make the best recommendations, the decision must take into account the opinions of two experts, the doctor and the patient, who's an expert in themselves. Patients really know what's most important to you, what you can tolerate, what level of uncertainty is okay with you, and what symptoms are, tolerable versus must be changed. And we'll see later that shared decision-making really requires two people at least to make a good decision. So what goes into making a complex decision? So what do I need to know to make complex decisions about health? So first, data on the likelihood of risks and benefits. So what are the chances that I suffer from some of these uncommon side effects of the treatment? Or what are the chances that the symptoms completely resolve? We must also know the level of certainty of the outcomes. So will this treatment completely resolve my pain, or will it only make my pain less intense and less frequent? And how much time do I expect for this to happen? Familiarity with the health issue. So how much of the condition do I know about? And which kind of plays into information sources. Where can I get more information if needed? My own values and beliefs. So at the core, what is most important to me as a person and as a patient? And because we don't live in isolation, how do my choices and my decisions really affect the people around me? And who on my team is supporting my decision, whether it be family, friends, loved ones, or even peer supports? And finally, past experiences. So my own experiences, as a patient, as a provider, but also shared experiences from other people who support me. So when I think about different models of medical decision-making, there's always going to be two parties. So in this case, the clinician or the provider, and then the patient. And the first type of medical decision-making is this traditional paternalistic model. So I, as the doctor, gives you my opinion, gives you my recommendation based on some information that I know. And I, as the doctor here, am the star player here because I'm providing all that information, just telling you what to do. So this paternalistic medical decision-making model, very doctor dominated. Now, the second model is kind of this informed decision-making. So in this model, I, as a doctor, my job is to share all this information with you. And your role as the patient or the consumer is that you take all that information and you run with it. So in contrast with the paternalistic model, this is more patient-centered. Right? You as a patient are the star player, patient-dominated, you're taking all this information. So in medicine, we often throw around this term informed decision-making, again, to mean that you as the consumer, you as a patient, are understanding the whole nature and the disease and the problem. And actually, many patients are not aware that you can and you should participate in decision-making. So parts of informed decision-making are really, for example, discussing the clinical issue. So clearly stating at hand, what is the issue? So for example, this medication could help with your blood pressure. This blood test will tell us this result, or this procedure that we do will let us know this. Okay, just really kind of very clear facts. Informed decision-making also involves discussing alternatives. So every decision is a choice between different options, right? If there's no choices, then there's no decision to make. So kind of walking through the different alternatives and different options. Discussing the pros or potential benefits as well as the cons. And this is to present really a balanced view of all different options that allows you as a patient's decision to be more informed. Discussing the uncertainties associated with that decision. And nothing in life, medicine, or healthcare is a sure bet. And honestly, we as doctors are not great at discussing uncertainties, but it's such an important part about having a thoughtful discussion about what to expect, what not to expect too. And then finally, assessing a patient's understanding. So really checking in, right? So if my job is to provide you all this information, it behooves me to also check in with you to make sure that this information has been received by you. Does this make sense? And then finally, this third model of shared decision-making, which kind of differs a little bit from the first two in that there's this two-way flow of information and sharing. So effective shared decision-making is this two-way flow where the provider kind of presents all this unbiased review of information, all the available options. The patient then brings his or her personal values, goals, preferences, circumstances, and together the clinician or the provider and the patient evaluate all the shared information to decide which treatment or which option is best aligns with the patient's needs and values. In other words, shared decision-making is kind of hitting that sweet spot between those first two models. So shared decision-making, the definition, is the process in which clinicians and patients work together. So I'll be using the word together a whole lot to decide on interventions based on the evidence that's out there and a patient's informed preferences. So as a physician, my knowledge and experience brought to the current situation and then integrating with patients' knowledge, preferences, experiences. Oops. The perfect situation for shared decision-making is actually when there is not clear evidence to support one option or the other option. So in this case, the best choice actually depends on really individual values on risk and benefits and treatments. It involves clear and accurate medical evidence about the options, the risk benefits, potential burdens. Again, the providers to communicate and kind of tailor that knowledge to the patients. And then most importantly, the patient's goals, preferences, and concerns. So shared decision-making is this very individualized approach because it tailors to the patient's goals and preferences. Like I mentioned, the most appropriate situation for shared decision-making is when we're uncertain about what the best choice is, or what's called a preference-sensitive choice. So a preference-sensitive choice, when there's multiple options, all very good. Patients, in this situation, patients can agree on what's best for them based on really how they value the benefits versus harms. And that decision ultimately is based on beliefs about response, like is this treatment, do I think it's going to work? Risk perception, how much do I think is worth gambling about this treatment? How severe the disease is, how much I can tolerate the symptoms as a patient, as well as education from providers, peers, the media, the world around us. And again, a preference-sensitive choice is defined by what's called clinical equipoise. Again, when things are not like if there's equally good options, and this is a perfect situation for shared decision-making. So recall, the couple slides back, we talked about the best decisions often involve expertise from multiple sources. So in medical decision-making, as a provider, where my strengths are is to bring you knowledge about the diagnosis, what causes the disease, the prognosis, what the disease is going to do, what treatment options and outcome probabilities. That's a lot based on population data, research studies, and trials. I'm counting on the patient's expertise because only the patient knows the impact of the condition it has on their daily life, how they experience the disease, how they perceive risk, what's their social circumstances, values, and preferences. And the beauty of shared decision-making is that it kind of integrates both of these and it takes both of these things into account. So again, shared decision-making components are knowledge delivered by the provider about effectiveness about the diagnostic tools or treatment options, reviewing the potential benefits and harms, asking the patient to think about what their preferences are, what was important to you, but then together, the patient and the provider decide on a care plan. Now, so this is exactly what it sounds like. It's a partnership between patients and providers. And so while shared decision-making is often viewed as this hallmark of good and very ethical clinical practice, and we often think, well, all doctors should do shared decision-making, right? I want to challenge you to think about it as also a way for you to enhance your ability to engage and activate as a patient. So in other words, practicing shared decision-making as a patient is a way to empower yourself and to take ownership of your own health journey in order to really maximize your own positive outcomes and improve experiences in care. Again, this is it's a two-way street, it's a two-way flow. So to review benefits of shared decision-making, there's many. And the first is that shared decision-making does increase patient knowledge. It's been shown to increase knowledge about healthcare options. It helps patients to be more clear about their own values and goals. Oftentimes, shared decision-making kind of forces you to put this hat on and think about, all right, what is really important to me and my family? Shared decision-making increases kind of this accurate perception of risk. So I may not know that I'm a kind of a risk-averse person, but kind of thinking through the exercising, I'm not willing to do that, or I am willing to do this and gamble on this treatment. Certainly, shared decision-making increases patient participation in care decisions, and then ultimately results in patients making more choices that are in line with their values. Shared decision-making increases healthcare communication and strengthens those patient-doctor relationships to make them into partnerships. And then on a more global kind of aspect, shared decision-making can increase treatment uptake and adherence. And the idea here is, as a patient, if you have some buy-in and we choose a therapy together that you think you'll stick to, you'll probably stick to it maybe a little bit better than if I just tell you to do it. Shared decision-making can increase satisfaction not only with the treatment that you choose or the option that you choose, but also with your care overall, and can decrease decisional conflict and uncertainty. So that struggle of, oh, I don't know what to do, and I don't really have any information. And then finally, the jury's still out about if shared decision making kind of moves the needle on decision regret. And that's a little bit more difficult because decision regret involves kind of looking retrospectively, oh, okay, well, that wasn't a decision, knowing, or well, that wasn't a great decision, knowing all the information that I have. So shared decision making sounds great and everything, but how do we actually know we're engaging in it, or at least in some parts of it? So in the next several slides, I'd like to walk you through some steps that I take when I'm practicing shared decision making, particularly in taking care of EOE. So step one, defining and explaining the problem. So in my practice as an adult gastroenterologist, mainly focused on EOE, I recently met a 63-year-old man who has EOE. His symptoms were mainly food getting stuck, hung up, and a lot of throat discomfort for at least 15 years. He was avoiding a lot of foods like dry chicken, crusty breads. But in reality, he was diagnosed with EOE about 10 years ago, but never treated. So here we kind of together reviewed the problem. Okay, the problem is you got persistent symptoms for at least 15 years. And on the other side of it, well, you got untreated, uncontrolled disease to explain the symptoms. Clearly, there's a problem here. Now, going through the different treatment options, when I think about EOE treatment options, I think of them with at least 3 different little buckets. And the first being medications. They exist in categories of PPIs or proton pump inhibitors or topical steroids. The second is diet elimination, where we kind of try to eliminate certain foods of the diet and determine which foods are trigger foods or safe foods to eat that make EOE better or worse. And then the third is endoscopic dilation, or kind of mechanically stretching out narrow areas of the esophagus. The fourth option we don't often think about because it's not exactly a treatment, but the fourth option is always to do nothing, right? Theoretically, if you think about this example, the patient has been untreated for about 15 years. We've been in this do nothing camp for about 15 or 10 years since we've known that he's had EOE. The next step is to discuss pros and cons. Now, there are many pros and cons to the various treatments of EOE, and so this is an example of them. We won't walk through this chart too much, but with the patient, we together kind of reviewed the benefits of medicines like PPIs and topical steroids, that being control of inflammation and symptoms associated with EOE, that the medicines are relatively easy to use and they act pretty quickly. But like all medicines, accompany different hurdles, like remembering to take the medicine or just it being inconvenient. And then little nuances like topical steroids, which can be very expensive sometimes. We also reviewed different pros and cons of the diet, that being, again, control of inflammation and symptoms. And for a lot of patients, controlling the disease without using a medicine is very appealing and kind of attacking EOE at the root cause. Major downsides of the diet are just kind of what they sound like, adhering to a strict diet. And then in order to kind of identify different food triggers or safe foods, several endoscopies are necessary. And I always tell patients it's a lot of time investment up front because we may spend 6 to 12 or more months together to figure out which food triggers are not safe to eat versus the ones that are okay to eat. And then finally, endoscopic dilation, which doesn't really control the inflammation, but can help you feel better if we're kind of stretching the esophagus out, but also comes with some disadvantages of needing repeated dilations if the disease is progressing. And also with, like any procedure, come with potential complications of pain, and then a small risk of what's called perforation, or kind of creating a tear or a hole in the bowel. The next step is what we took was kind of reviewing the patient values and preferences. So here I kind of asked the patient, well, what's important to you, knowing all these different treatments? And he told me, well, eating his favorite foods without any limitations is the most important, hands down. He was willing to try some medications, but he was a little bit iffy on using topical steroids or steroids long-term. But he was feeling okay, pretty neutral about needing repeated endoscopies. We next discussed patients' ability or self-efficacy. And what this means is kind of this individual belief of your own abilities based on how confident or what control over the situation you have. So in other words, what's my ability to actually get this treatment done? Or in the case of this patient, how confident am I that I can pull off this treatment regimen and stick to it? So he told me adhering to a restrictive diet is just not possible. He said, I know myself, I just will not be able to stick to it. However, he was pretty confident that he could remember to take medications twice a day. And looking at his life and work schedule, he was able to work in a schedule endoscopies if we needed to. Next, we kind of revisited, the doctor's point of view, knowledge, and recommendation. So here comes me integrating my knowledge and what I'm hearing from the patient. So I said, the elimination diet, so removing things like dairy, wheat, soy, eggs, or even more, is probably not in line with his preferences. However, he probably had a fair chance of success with a medicine like a PPI, like omeprazole, as these medicines can be ineffective in up to 50% of EOE patients. As a result, we talked about the potential benefits and risks of this medicine's PPI. And then alternatives, like as topical steroids as a backup plan. So what are the potential risks and benefits of a topical steroid if the PPI didn't work? And then finally, the timing and the need for this next endoscopy. When would we look? Why do we look? The next very important step is checking in and clarifying about these options, right? I dumped all this information at you. Now, is that being digested? So the patient actually came back to me and said, okay, the medication options I think I have are proton pump inhibitors like omeprazole, or even topical steroids, like some swallowed inhaler or something I mix up and swallow. But if I take the proton pump inhibitor, the omeprazole, does that mean I have acid reflux? Because this medicine is commonly used for acid reflux. Do I need a scope to make sure this treatment's working? How will I know? And what are the chances this doesn't work? And finally, what happens if I need a dilation? What does that mean? And that was a great opportunity for us to continue having this dialogue and say, okay, let's walk through all these questions and concerns. And sometimes this process may result in more questions. We kind of go back and forth. And then almost finally, kind of the next step is to make or defer the decision. So I said to the patient, well, it kind of sounds like you're leaning towards trying a PPI first. And he thought, okay, this is the easiest and safest bit, but I'm not 100% sold yet. So I said, how about discussing some of these options with your family? You don't have to decide right now in this room in the next 20 minutes, you don't have to decide. And he thought that was a pretty good plan. Well, I'll check with my wife, I'll talk it over with my family, and I'll let you know. And then the most important step for the shared decision making is arranging follow-up. And that might look like scheduling a next test or discussing the results afterwards, or even discussing a further time we can continue this discussion. So we said, okay, since we didn't make a decision exactly, let's plan to check back in a month. But if you decide sooner, if you talk to your wife tonight and you decide, oh, I want to do this, let me know, we can start some treatment. In the meantime, if any questions or concerns come up, let's have them. Please ask, because we won't make any plans or any decisions that you're not comfortable with. So that's kind of a glimpse of what shared decision making looks like in my clinic, but I understand that's a very specific example in EOE in an adult. And there's actually several shared decision making tools out there, mostly developed for research purposes, but I wanted to showcase this one called SDM9 just as a checklist that's a little bit more patient facing. So think about these next couple of options. So my doctor made clear that a decision needs to be made. My doctor wanted to know exactly how I wanted to be involved in the decision. My doctor told me there are different options for treatment of my medical condition. My doctor precisely explained the advantages and disadvantages of the treatment options. My doctor helped me to understand all of that information. My doctor asked me which treatment I would prefer. My doctor and I together thoroughly weighed the different options. My doctor and I selected a treatment together. And then finally, my doctor and I reached an agreement on how to proceed. So I think the last three are actually the most precious to me because it's my doctor and I. We're together doing a process, and those are key features of shared decision making. So how do you broach this topic of shared decision making with your doctor? So to review, shared decision making requires providers to offer this unbiased, the latest evidence-based knowledge, patients to clarify what their values and preferences are, and then open communication between the both. So since the third component of shared decision making is communication, I would urge you to set an agenda on what questions and concerns that you have and prioritize these with your provider, right? We all have agendas coming into the clinic visit. We as providers prepare, and we know most of the time we know what we're going to say. So it's important that you prepare and bring that piece, and you make it known that you also want to talk about certain things. Express your understanding of your condition and what you've been told. So I love this piece. I typically walk into a visit and I ask people, what does EOE mean to you? And what have you been told about EOE? Kind of as a jump off point of what we're going to talk about next. Let your provider know how you want to be involved in the decision-making process. True story, for some visits, some people tell me that they don't want to be involved at all. They would just rather me make the decisions for them. And some people want to have buy-in. And both of those are totally okay. And then finally, share some things. Share what concerns or worries you about this condition. What do you want out of the treatment options or treatments or options, right? So sometimes the priorities that we as providers have are very different from what you want to get out of this. What do you already know about the treatments or options? And what concerns you about any potential risks? So again, effective shared decision-making is kind of this flow of information, again, where patients share their personal values and goals, their circumstances, the provider, and as well as the provider kind of brings this unbiased view of evidence-based knowledge. Again, together, the clinician and the patient evaluate the shared information and decide which option best aligns with the patient's treatments or needs. Shared decision-making is not a one-time event, okay? And depending on the decision, this process could take minutes, hours, weeks, or in many cases in the last year, months. So when can I apply shared decision-making in my health, right? So again, shared decision-making, perfect situation is in preference-sensitive situations. So shared decision-making might not be appropriate where there's very clearly one medical treatment that's best. So for example, whether or not to use an antibiotic to treat a life-threatening infection like appendicitis, right? There's one very bad option and one pretty great option. Shared decision-making, not the best time. But shared decision-making can be great when there's a new diagnosis, so you don't really know about the different treatments. You need to get that knowledge. When the disease prognosis or the disease is changing or something is changing about the decision, okay, to treat, a change in your health status, when you're about to enter a clinical trial. So say you've kind of exhausted standard treatments and we're looking at the next tier, what are the options in terms of trials? There's a lot of risks and benefits there versus trying, some other therapies. Screening tests or preventative strategies are a great place for shared decision-making. So for example, screening is done when we don't know we have a disease yet. You're checking to see what your risks are for developing it. And then finally, shared decision-making is great when life throws you curveballs, right? When life changes things that alter your priorities, whether your family, finances, caregiver support, great moment to stop and kind of pivot that discussion. So why doesn't shared decision-making happen all the time? Now, answering this question is a little bit challenging because shared decision-making involves two parties. So I can only propose kind of barriers that I see from a provider standpoint. Providers often think that we're doing shared decision-making, but we might not. So again, shared decision-making hinges on us having access to the latest evidence-based knowledge. That doesn't always happen. Shared decision-making also depends on providers being trained. And realistically, in our training, we often are not taught thoroughly about how to engage people in it. Some providers do think that patients don't want shared decision making, or that patients don't want to be part of the decision making process. And then in realistic real life practice, time is an issue, right? If you think about your visit with your doctor, sometimes you get 15 to 30 minutes. And like I mentioned, shared decision making is not a one-time event. You can't knock it out in 30 minutes. And oftentimes it's a back and forth conversation. It's creating a relationship. And so sometimes time crunches can be limiting and difficult for providers. Decision aid tools are tools that kind of support shared decision making. They provide information about treatments, usually have some sort of exercise to help patients clarify, okay, these are my preferences, these are my values, by kind of laying out all the options, and also facilitate effective communication between patients, families, and doctors. Okay, and so sometimes that might look like a pamphlet, maybe even a list of questions of how to prepare yourself for the visit, or kind of forcing you to do a pros cons list, kind of weigh out what you think are important. Decision aids can improve accurate perceptions of risk. Again, kind of like, am I willing to gamble on this treatment? Yes or no. Help patients to make decisions that are aligned with your goals and preferences by really getting down to what are your goals and preferences, and then can make making decisions a lot more comfortable. So how do you handle decisions or situations where you and the doctor don't necessarily agree? We as providers often assume that patients will speak up if you disagree, but that's just not always the case. So a key part of decision making is knowing that it is okay and it is appropriate to disagree and ask for more time. You have to remember that you are your own best medical advocate, or the advocate for your family members. So get the facts, always consider the needs and values and what you hope to be the best possible outcome. Remember that the best possible outcome for you as a patient is not necessarily the same one that I would choose for myself or my loved one. Remember that you're not alone. It's so important to seek out help from other patients, family, friends, really kind of having these awesome peer support groups like APFED. Active listening. When I think of this, I think of kind of ways to kind of jump into a visit fully prepared and just gather all that information. So preparing for appointments, maybe with a list of questions. I personally love when patients do this. And that way we can kind of tackle through all the concerns that you come prepared with. Take notes during the visit, or even have someone there with you to take notes. That way we can kind of jog through some of those questions even after the visit, after visit's over. And of course, if something doesn't make sense, ask your doctor for clarification. I think as physicians, we are trained to speak at a weird and different language, and we don't even know we're doing it half the time. So if it doesn't make sense, stop us and ask to break it down in a way that you understand. Communicate what you care about. Again, the things that you care about may be very different from the things that I care about or the next person cares about. And then again, take time to decide. Oftentimes, you have more time than just that 15 minutes. And you should be mulling over these thoughts to make the best decision for yourself. And then finally, looking at some resources. I really like this book called Critical Decisions. If you have some light, end of summer reading, how you and your doctor can make the right medical decisions together. Kind of looks at, how patients and doctors can learn to be partners and work together to make the right choices. There is a cool online tool at the Dartmouth website. And it has these decision points, and for different medications, procedures, and you can kind of scroll through them. It presents different risk kind of numbers and pros and cons through. You can kind of toggle through. And then finally, this is a little lengthy, but the Ottawa Personal Decision Tool is this cool tool that's designed to really help people walk through any health or social decision. It kind of guides you through to assess your decision-making needs, think about what's important to you, and then kind of planning the next steps. So I have this, this is the decision guide here. It's a little busy, but you can see even at the top left corner, what decisions you have to face. I recently walked through this with my husband to decide whether or not I should take on doing a kitchen renovation by myself. What do I need? What knowledge? What skills do I have? Is anyone helping me? And then kind of in the second page, how do I plan to either do this now or kind of table it, ask for help, what's important? And so this can be kind of fun to walk through. You can use this to make any decision in your life. So I think it's just an exercise to help you think through difficult discussions. And with that, I'm happy to take any questions. Thank you.
Thank you so much, Dr. Chang. We really appreciate you taking the time to go through all of these wonderful information to help people learn more about shared decision making. So we do have a few questions that have come in, and let's see, the first one is actually pretty specific to some of your own personal practices. What do you see with PPIs? Do you see that some carry greater risks than others? Like if people are trying to make a decision between different types of PPIs, what types of questions they could be asking and considering?
That's a great question. I think to my knowledge, and besides EOE, I also take care of lots of other people with esophageal disease. So I also use a lot of PPIs for reflux. So to say the least, I use PPIs a lot. To my knowledge, the evidence has not come out with any specific particular increased risk in terms of different PPIs. So some PPIs may be chosen because they may be more potent. So for reflux, we may, if one more watery one isn't working, we might kind of step up to the more potent ones. But in terms of starting out with a PPI, oftentimes we kind of start out with the most available omeprazole necessarily, because there isn't necessarily information to say, oh, wow, this one's a dangerous one versus this one's a much better one to start out with. They're kind of all cousins of each other.
That makes sense. The question kind of had a follow-up part too of that in some cases they were told that they should only take the specific PPI they're on for about 6 months and that they shouldn't take it for longer than that because of increased risks. Is that something that you see in your experience?
That's a great question. I think in all things, that conversation always comes with discussing the risks and the benefits. It depends on what we're using it for, right? So if you have rip-roaring reflux and when you come off that medicine, there's bad acid damage, coming off that medicine is probably not a good idea. Versus, is it pretty mild and we can come off or taper that medicine a little bit? Is that worth it? Maybe, it's very individual. And there's been a lot, I think PPIs have gotten a bad rep lately. And there's been a lot of great research kind of battling that a little bit to say, all right, what is the evidence? Is all these really bad, scary things really going to happen in the long term? Some of that evidence is not fully there. And so it always still comes down to what are the potential risks, right? And what are the potential benefits? If the benefit that you get is very clear, controlling your EOE, controlling your acid reflux, that is probably a little bit higher than the potential risk that one of these bad things might happen to you in 30 years. And so that's always a conversation that you have to. But the decision to start or be on the PPI and stay on the PPI, it should be made after you have that discussion. Being like risks, benefits, nothing is zero, nothing is 100%, but where do I land in the middle?
If someone is considering the difference between PPIs and some of the swallows or the inhalers that they swallow, what are some good questions that they can ask their own doctor to help make that decision of one, the other, a combination?
I think part of it, so knowing that, the studies have shown us that PPIs are not effective in everybody. The steroids tend to be a little bit more effective in a lot more people, but steroids carry different kind of stigma, as do PPIs. I think of it, if you're going to put them all equally, think of a PPI as a pill that you can get pretty easily either over the counter at your pharmacy. Just take the pill, it's already made for you. Whereas the kind of the Flovent puffer or mixing up the budesonide have a little bit of extra steps in them. So, having a full understanding of what it looks like to try taking that Flovent or even mixing up the budesonide, kind of the instructions and how to actually do it practically may take into account of what you choose, right? If I have a patient who's very on the go, I don't really have time to mix this scoop up and take it, the FlowVit puffer in my backpack is probably a better option, something like that. So what practically works with your life is that's going to control your EOE better, works for me.
That makes a lot of sense. One of the things you talked about at the beginning of your presentation was about how important in shared decision making is that the doctor is providing the most up-to-date research. As a patient, how can you tell if the information you're receiving is the most up-to-date? And what do you do if your doctor does not present that information? Like, how do you share that information with them if you're trying to have this shared decision-making discussion?
Right. That's always delicate conversations, right? Like, what if you know more than your doctor? I think there are so many great sources of information about EOE. There's also lots of bad ones too. And I think, great professional sites like some of the GI sites, APFED, the other patient advocacy, kind of help to synthesize, where that good information is. I think the struggle is finding information that makes sense to everybody, to you as a patient particularly. But those difficult situations, I definitely hear those stories too, being like, well, I was told that, I can't do this for treatment. I think you do your best to educate the provider. I know it's not the patient's job to educate the provider, but again, at the end of the day, shared decision making is a partnership. And so if one partner is not willing to dance, that seeking a second opinion is not a bad idea. I'm not encouraging it, but if you're not making any headway, again, your social network, whether that be your friends, your family, other people who have more experience, are also part of your armamentarium. So if your provider is not hearing you and is not willing, then turning to other resources, being like, okay, where else can I reach for help? Because at the end of the day, it's your health, right?
Absolutely. So if you've never engaged with your doctor in a shared decision-making model, what would be the best way to broach or request that to happen?
I think just jumping into it. I mean, it's weird, right? You're like, a lot of people don't think of like, oh, this is a partnership. Sometimes I go to take my car in because that person has expertise. I don't tell them what to do, but that's what's unique about shared decision making, right? It kind of turns the whole model on its head a little bit. Your job is not just to consume information from me, and my job is not to tell you what to do. A little bit, but we kind of do this back and forth dialogue. And so kind of having those questions, first of all, is the first step, right? If you come in, you've thought really carefully through what your questions are, that's already starting a dialogue. If I can respond to those questions, great. Even better if you can say, this is what's important to me, because providers may not know to ask, hey, what does your day-to-day look like? Like, can you actually make this happen? We don't always do that, I don't always do that. But if you can come out and just share that with me, that's a huge first step. Ask questions, because I'm good at answering questions, but ask questions, but even go next step to tell me what matters to you.
That's really helpful. The other thing you shared while you were talking were some nice checklists and screenshots of them. People are very interested in accessing some of those. Where can they find them?
The checklists at, I guess, at the very end, or
any of the checklists that you had that were helping people to be able to have conversations. You mentioned them a few times throughout your presentation.
So I think the copy of these slides will be available. So if the checklists are there, the other, I think, of the three resources, the only one that might not be there is kind of that Dartmouth decision points link, which we can embed as well. But otherwise, I think all of that list of kind of, is my doctor doing this? My doctor doing this? Those will all be on the slides that you can download.
Great, absolutely. Going back to PPIs again a little bit, we have a question about eosinophils increasing. So in discussion about PPI, my eosinophils increased after being on PPI. Is there a reason that would happen? What questions can I ask my doctor? They don't seem to know.
Okay. I guess that might be a little nuanced in terms of how much did your eosinophils increase. There's not great data to show that PPIs actually cause EOE. I know there's like I've heard this like through the community and stuff, and kind of dangers of PPIs, but sometimes in my own practice, I see, hey, I try someone on PPI and the eosinophil number doesn't decrease. So either it stays the same or it kind of goes up a little bit. And that might be kind of the situation that you're talking about. EOE is a patchy disease. So I always tell people, the number of eosinophils you get on the biopsies depends on the person counting them, or the pathologist, but also where I grab the biopsies from. So some place in your esophagus, you may have 100 here, 50 here, 20 here, 10 here. But if the endoscopist is grabbing from an area that has 30 and 20, and then, the PPI is not working, I happen to grab from an area that has more eosinophils, that might be because we call it a sampling bias. You might see more eosinophils only because you're grabbing from a different place. So it's not necessarily true that PPI is causing that bump. Maybe the PPI is not doing anything at all, and I'm just seeing just regular EOE that was always there. So that's a little tricky. That's a little tricky. I think kind of taking a step back and, I think how to approach that with your physician is hard because, that person may or may not be as knowledgeable of EOE, but I think kind of asking these questions is an important part of getting what could be explaining that bump? It may not be an actual bump, just might be more EOE.
More questions to ask, absolutely. When you were talking about how people don't always make decisions during that initial meeting with you and how it might follow up with things, do you have tips on what that follow-up communication could look like? Certainly, does every follow-up conversation have to be another follow-up appointment? How does that work when you step away to go have conversations and make some internal decisions?
That's a great question. And I think I've tried to do it a couple ways. So sometimes I'll schedule an appointment and I'll say, let's talk in 3 months. That doesn't always result in good stuff either, because I shouldn't put a time limit on how long you take to decide. So recently, in the last year or so, I've been trying on this. All right, you go talk about it with your family. You decide on your own pace, because there's other things going on in life. You may not schedule this meeting with your family and have an answer for me. And you let me know when you're ready, right? So I do rely heavily on kind of messaging patients through the portal. And so does that mean that sometimes I lose people to the nether? Sure. But sometimes people do come back, and I think the bottom line is it's a decision for you to come to. For example, the patient example that I had, this guy had EOE for at least like 15 years, wasn't treated for 10 years, but why suddenly kind of bubbled up in my clinic? He was just ready to tackle it. That's all. And so when you're ready to tackle it, you let me know. And I think there are some diseases where this does not work, right? Like cancer, for example, where a decision needs to be made a little bit sooner. Realistically, for diseases like EOE, most of the people that I see have probably had their symptoms and had the disease for a really long time. What's another day or a week that you can think about it and really, talk about with your family what your choices are, and then come to something that's really going to work for you. I understand that a clinic visit that is 15 to 30 minutes is probably not enough time for me to say, all right, tell me what you want, decide what you want, that's probably not a great decision. But putting kind of the responsibility in the patient's hands to say, you come back to me when you're ready. And sometimes that means that you're not ready to make a decision, or you're not ready to start treatment. And that's, I think you show, it's showing me with your feet which way you want to go. You want to start right now or shop around and come. That's okay, because again, this is a partnership. I can't make you do anything you don't want to do.
It leads into another question that came up of if the patient is leaning towards a decision that the doctor perhaps or clinician is not necessarily agreeing with, What is a good way to communicate that back to your clinician so that they don't feel disrespected?
Yeah, that's tough. I think being informed, right, with the right information is so key. So if, for example, APFED has lots of the most up-to-date evidence-based knowledge saying, hey, well, what about this? I'm seeing this study, do you mind looking into this a little bit? Patients ask me that too all the time. What about this study? And my job as not only a researcher is also to say, oh yeah, I didn't see that. Let me think about that. Or I have some patients who say, hey, like, what about this random, like, this device that I saw? Because this helped with my choking or things like that. And it's my job to say, oh, actually, I never heard about that, but let me look at that and let you know if I think it's safe or not. And again, that's my opinion. I'm going to tell you if it's safe or not, or if it's a good idea. But I think that's a huge step to say, to not be afraid to be like, oh, what about this? If the provider still says, no, I don't believe it, that, that exposes a lot of vulnerabilities, even in our own practice, right? It's not easy for a doctor to say, I don't know, or I'm not up to date, and that might be true. But if you're acting as your best own medical advocate, that sometimes may come to, all right, well, I'm going to go see if another expert has, any thoughts. And it's true. Sometimes patients see second opinions, third opinions, break the tie. There's no harm in shopping around, and, hearing different perspectives.
I appreciate that. And it is, it's hard. Not everybody agrees with the same course of what to do. And so that shared decision making introduces a whole new level of conversations between people. A similar question came in where people are curious if the clinician does not want to do multiple EGDs with the food elimination diet. What do you do?
That is something that I do see too, I think there is a good body of evidence out there showing that symptoms are just not good enough to rely on, right? And I think I know the situation you're talking about too. People get started on this diet, like, hey, go avoid these foods, and then see you later, just do it, my take is very much not, I love to do endoscopy, but I know that, not, it's very inconvenient and other, but the bottom line is, if I'm going to do something to you, whether it be medicines or diet, we kind of owe it to you as you deserve as a patient to know if it's working or not. Unfortunately, in 2021, endoscopy is the only way that we have that reliably tells us, what the EOE is doing. I think that, there is a lot of evidence out there showing that you just can't rely on symptoms. And so similar situation, kind of presenting that to the physician saying, hey, like, I don't think I'm getting like symptom benefit, or I can't tell if this diet's working for me at all. And even directing them to some evidence that, biopsies could provide some objective evidence. But that's, again, kind of stepping out of comfort to saying, I'm not challenging you, but if this is a partnership, this is a relationship, like I'm trying to help myself to get the best answer.
Thank you so much for answering all of the questions that came in today. We really appreciate your support for today's webinar. Along with the support of our education partners. Thank you very much to AstraZeneca, to Bristol Myers Squibb, as well as to Takeda for sponsoring APFED's Eos Support Webinar Series. In addition to the webinar today, we also want to tell you about some other resources that can help you continue to learn more about eosinophil-associated diseases. This summer, we held our virtual conference. So we annually hold a patient education conference on eosinophil-associated diseases. And this year it was virtual. And one of the great benefits of that is even though it's already passed, you can still access it. So please, we encourage you to go to apfed.org/conference. You can log in and access all of the presentation recordings. You can still go through the exhibit hall and the poster hall to really engage with all the wonderful content that's there. Also, please tune into our new podcast, Real Talk, Eosinophilic Diseases. You can listen to this anywhere you can subscribe to podcasts. Our most recent episode was about self-advocating with an eosinophil disease. So it's covering very similar topic to what we addressed today, but from the patient perspective. So today we had the wonderful opportunity to talk with Dr. Chang. And if you listen to the latest podcast episode, you can hear from Debbie Alves, who is a patient with hypereosinophilic syndrome. Also, some other opportunities to engage with us. On September 20th, we, along with a few other organizations, are co-hosting a virtual externally led patient-focused drug development meeting, also known as a PFDD meeting. This meeting is specifically going to be about living with and managing asthma in childhood. If you or your loved ones experience asthma in childhood, please go to littleairwaysbigvoices.org. Check out more information about the initiative. Please attend the event. And in addition to attending the event, there's also opportunity to participate in a survey as well as submit written comments. This event is going to help inform the FDA and key stakeholders about information about the future of treatment for asthma in childhood. Thank you so much for joining us today. If you have any questions, please email mail@apfed.org. And also check out apfed.org/webinars for more upcoming webinars. We've got some great ones that we're going to be opening registration soon for October, and we hope to see you soon. So thank you again, Dr. Chang. We really appreciate you joining us today.
Thanks. Have a great week, guys.
Bye, everyone.